Welcome to the World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global healthcare. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high-stakes, critical, and emergency situations. WICCEM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary, cardiovascular, and neurology specialties. From advanced training in emerging techniques to hands-on experiences in critical care, life support, and emergency medicine, our programs are designed to equip you with the skills needed to thrive in demanding environments. Our expert faculty, who offer lectures, mentorship, and innovative insights through annual conferences and webinars. With our online learning platform, you can access courses, workshops, and a rich library of resources from anywhere in the world, making education accessible no matter your location. WICCEM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare.
Hello, everyone, and welcome to our first Critical Care Pediatric Fellowship free webinars. I'm Dr. Amr Hosseini. I'm a professor and I work in Kentucky, USA. And today we have very special webinar. We have Dr. 𝒂𝒏𝒂𝒍𝒍𝒚 from UK. We have Dr. Anna Goons from Canada, Dr. Shegan from South Africa, Dr. Heba from Cairo University, Egypt, Dr. 𝒂𝒏𝒂𝒈𝒊𝒏𝒈 from Saudi Arabia, Dr. 𝑪𝒓𝒊𝒕𝒊𝒄𝒂𝒍𝒍𝒚 from South Africa, and Dr. Michael Canary from United States. So very diverse, very strong speakers and moderators. Here is our today's webinar agenda. I'm going to give you an introduction about our fellowship. Then Dr. Shegan is going to give you some samples from our Pediatric Critical Care Fellowship. Then we will have our first talk by Dr. 𝒂𝒏𝒂𝒍𝒍𝒚. She's going to focus on cardiorespiratory deterioration of sick child. Then Dr. 𝒂𝒂𝒂𝒈𝒊𝒏𝒈 and Dr. 𝒂𝒏𝒂𝒑𝒊𝒄𝒂𝒍𝒑 are going to handle the question and answer with Dr. 𝒂𝒑. Then the next talk will be about deteriorating septic child, and Professor Anna Goons will be our guest speaker. Then Dr. Heba from Cairo University is going to handle the discussion with Dr. Anna. Then Dr. Michael Canary is going to give us the closing remarks. So again, we are structuring Pediatric Critical Care Fellowship. It's 1 year fellowship program. And because we know from the learning pyramid that the retention rate is very low when we give lecture or when we read, we try to use more audio visuals, demonstration, to use bidirectional discussion, dialogues more than monologues. And we are trying to help you to implement and disseminate and apply this knowledge in your clinical practice, and also will help our fellows to teach so they would have the best retention rate. Again, our fellowship is 1 year and it's wholly online, structured as 3 modules, 16 weeks each, and it's real education, not based only on webinars or seminars. So there will be weekly lectures, journal clubs, MCQs, clinical case scenarios. All of these materials will be released in a smart platform throughout the whole year. So again, this is the way we teach to involve our fellows in the educational process. So all scientific materials will be released in the smart platform at the beginning of each week on Monday, 8 a.m. GMT, and all of our fellows will have the luxury to navigate throughout this scientific material during the whole week. Then they need to turn in their assignments and tasks before the end of each week. So Sunday midnight GMT. So that's very important, and this will happen throughout the whole year. And all our fellows' activities and assignments will be monitored in the platform with weekly quantitative and qualitative evaluation, and we'll send our fellows' performance report based on their engagement and activities in the platform. So here is the syllabus of our fellowship program. The first module will be focusing on the basics of pediatric critical care field. So we'll focus at the beginning on recognition and risk assessment scores for pediatric critical illness, then transport and stabilization of critically ill child. Then we'll focus on shock. And every 4th week, we will have a live webinar like the one that we have right now. Then the next mini module will be focusing on essential concepts in pediatric critical care. We'll do 1 week education on nutrition and critically ill child. We'll do a point of care ultrasound in acute settings. We'll teach the pharmacology and holistic approach and patient safety. And we'll then go to infectious disease with the healthcare associated infection, community associated infection, sepsis, systemic inflammatory response syndrome, multi-organ failure, DIC. Then before the end of each module will be an exit exam for a couple weeks. Then module 2, which will be another 16 weeks of education on specialized systems. So we'll start with respiratory critical care education, focus first on basic respiratory physiology and conventional mechanical ventilation, then non-invasive and non-conventional mechanical ventilation, then restrictive and obstructive lung disease. Then we'll move on from respiratory to cardiovascular system. We'll do first cardiopulmonary interaction, hemodynamic assessment, cardiovascular therapeutics. Then we'll focus on arrhythmia, post-operative cardiac care, and mechanical circulatory support. The last month of module 2 will be focusing on the renal critical care with fluid electrolyte acid-base abnormalities, AKI, and renal replacement therapy. And again, there will be exams for a couple weeks before we move on to module 3, which is advanced critical care training. Start with neurocritical care and endocrine, metabolic, oncological, and gastrointestinal disorder. Then the last mini module will be focusing on trauma patients, burns, natural disasters, pandemic, drug overload, and environmental and toxicology, and the PICU. Then the last week will be dedicated for ethics, inequalities, family communication with beings, and the critical care practice in resource-limited setting. This will be followed by the final exam. Again, upon completion of this program, we are expecting that all of our pediatric critical care fellows will be expert in the field then they are going to graduate to a terminal and mental level, and they are going to receive an American accredited graduation certificate from the American Association of Continuing Medical Education. All of this is what we are doing is aiming to improve our children outcomes, improve our sick children outcomes, because knowledge is of no value until we change it and put it in our clinical practice. And the great aim of education is not the knowledge itself, but how to implement and how to improve our patients' outcome. With that, I'm going to stop by here, and I'm going to let Dr. Shigan from South Africa to give you some samples of the materials that will be delivered during this pediatric critical care fellowship.
Good evening, everyone. Just before I begin, Prof. Amr, can you see my screen? I just want to make sure it's working.
Yes.
Okay, perfect. So everyone, my name is Shagan Irison. I'm a pediatric nephrologist, and I'm presently delving into critical care here in Cape Town. I'm affiliated to the Stellenbosch University, and I'm very happy to speak and represent the World Institute of Critical Care and Emergency Medicine. So as Prof. Amr said, I'm just going to give an overview on what our educational tools are like and how we will teach and show you guys further. So if you were to just Google quickly, the World Institute of Critical Care and Emergency Medicine, you'll land on our landing page, where you'll have the opportunity to see many of our fellowships that are being created and other educational options. When you do get there, we would just like to welcome you to the Critical Care Fellowship, and this is what you'll see. Sorry. So what are our program goals? To support advanced training, to develop expertise in pediatric critical care, physiology, pharmacology, and procedural skill, to foster these skills within a team. And so importantly, all candidates that do decide to join us, just to remember, you are part of a group, so we can always communicate with one another and discuss some difficult cases. And hopefully this will help you take on a leadership role within a pediatric critical care setting in your environment. So the first thing that I just showed you, so this is just a screenshot that I took of one of our lectures. And this here will basically just give you, as you can see, a description of the approach to the various forms of shock. They are voice-overed, so that will give you an opportunity as well. And then you'll move on to multiple choice questions like this. We're describing a 10-year-old boy with acute kidney injury and hemolytic uremic syndrome. And as you can see, you're provided with a few blood results. And then the question comes into, how will you interpret this, and what form of acidosis is it mixed, or are there multiple mechanisms in play? And whether you know or don't know, you do select your answer. And then importantly, the platform does give you that answer. And importantly, it also shows you how to come to that answer. And I think that's important in the learning process, that we just understand why we say something is, instead of just taking it at face value. And importantly, right at the bottom is you will be provided with a reference that you can read in your own time to try and reinforce the theory that we're trying to go through with you. Our next method is through a journal club. You will see that it comes through popular journals. This is from PedsNeph, published in April of 23. It's a new perspective on dialysis for neonates and infants. And you'll be able to download this journal. You won't have to pay for it. You can keep it on your computer and reference it whenever you need to. But importantly, as you move on, there are questions specifically to that journal to assess what your comprehension is and how you have internalized that material. So as you can see here, what is the incidence of AKI amongst critically ill neonates within the NICU? And there are a few options. You can see that the correct answer is given to you. And then again, the definitions and how we came to that answer is also provided. So just to give you a bit more explanation. So we've done a lecture, we've done multiple choices, we've done a journal club. And then finally, we move on to this, which is a case report, or case study rather. So here, it's quite a long story, but you have a 4-year-old girl who presents with a clinical situation of respiratory distress and tachycardia and a relatively low blood pressure with poor perfusion. Some therapeutic methods are initiated, as well as inotropes. You see some improvement. And then you get a few blood results that you have to interpret. And then they give you the rest of the vignette describes what happens to this child and how she proceeds, how she progresses over the course of the next day, how her results deteriorate. And then there is a question specifically on that. So as you can see, we focused on acute kidney injury in the ICU setting. But this here asks us, how would you characterize this? And this is a question I commonly ask my registrars or the medical officers rotating in our ICU, just so that they can describe and anticipate. And again, the answer is given, as well as the explanation and the direct reference. And I mean, the KDIGO guidelines are widely available on the internet. They are very long, but they are a reference standard that I'd highly recommend. So again, I just took the screenshot from the actual platform. So as you can see, if you select the correct answer, it is highlighted in green. The explanation is there as well as the reference. And if you choose the wrong answer, it'll just be highlighted in red. But the correct answer is then given to you again in green, so you can see what we'd like you to learn. So we do hope you join us. There is learning in many different forms, and we hope you're as excited as we are. And so thank you very much for your time.
Thank you, Dr. Shagan, for this nice review about the WICCAM fellowship. It's my pleasure, me and my colleague Asma Solo, to moderate this scientific webinar. Dr. Asma Solo, she's a consultant pediatric intensivist from South Africa and a board member in this fellowship, and me, Dr. Turki, consultant pediatric intensivist from Saudi Arabia. Our pleasure to introduce the first speaker, Dr. 𝑪𝒉𝒂𝒍𝒍𝒚, who's a former consultant pediatrics at Kingdom of Saudi Arabia. And now she's a clinical fellow of pediatric critical care at St. George University Hospital in London. And she is one of the board member of WICCAM Pediatric Critical Care Fellowship. And she will talk about the cardiorespiratory deterioration child. So welcome, Dr. Rihab, and the floor for you.
Thank you, Dr. Turki, for the presentation. And thank you, Dr. Amr, for the invitation. It's a pleasure being with all of you today. So today I'm going to present a case scenario about a deteriorating respiratory infant. And as I used with my audience, I'm encouraging them to interact with me on the chat and in the Q&A windows. You are the PICU registrar during your night shift, and you have been called to review a deteriorating 6-month-old infant who is admitted to the pediatric ward under the working diagnosis of acute bronchiolitis. The pediatric ward registrar is concerned that the infant is deteriorating, and he has a worsening work of breathing despite they did everything for acute bronchiolitis like saline nebulizer, oxygen therapy, and the chest physiotherapy. The background of the infant, he was born at full term via normal vaginal delivery, and he has an unremarkable perinatal history, and he's up to date with immunizations. And over the past 3 days, he developed the lethargy, poor feeding, cough, rhinorrhea, and low-grade fever. And this happened after he was exposed to an older sibling who attends nursery and recently developed upper respiratory tract infection. So of course, as a PICU registrar during the night, you attended the case physically in the pediatric ward and you started doing your clinical assessment. So this is the assessment of the patient. His airway was patent, but he was at tachypnic respiratory rate of 75, coastal and intercoastal retractions, and bilateral diffuse wheezes. His saturation is 90% on 2 liters oxygen, and his tachycardic heart rate 180, his blood pressure 75/45, and he has a delayed capillary refill time of 5 seconds and dry nappy for 6 hours. He's drowsy and his pupils are equal and reactive, and his random glucose is 100. He has a low-grade fever of 37.8, and he's on 2/3 fluid maintenance given to him via nasogastric tube bolus feeding. He's not on any antibiotics, and he has a 2 peripheral IV cannulas. So the case was identified as acute viral bronchiolitis, complicated by circulatory compromise, and it was thought by the attending pediatric registrar that the shock is related to inadequate fluid intake. So high flow nasal cannula oxygen was applied, and a bolus fluid of 10 mils per kilo saline started, and blood gas was sent, and you ordered a repeat chest X-ray. After 10 minutes of giving the bolus saline, you did your reassessment. So the vital signs are getting worse. His heart rate is 190 and respiratory rate is 70, and his blood pressure is 65/35, and his saturation dropped to 88% despite the high flow nasal cannula. He has a nasal flaring and chest examination. He has a persistent wheezing and newly developed diffuse bilateral crepitations and marked subcostal and retractions and increased work of breathing. You can now hear a galoprism on cardiac examination, and he has a newly developed hepatomegaly, so the liver edge is 4 centimeters below the costal margin. He's still drowsy, and his pupils are still equal and reactive, and he's still having a prolonged capillary fill time, 5 seconds. He's mottled, and he has cold peripheries. And this is his repeat blood gas. He has a pH of 7.15 and PCO2 50 and PO2 of 55, and bicarb is 16, and his lactate is high, it's 5. And this is his repeat chest X-ray with a significant cardiomegaly and pulmonary edema. So you called your consultant for advice, and he advised you to do a 12 leads ECG in order to confirm the diagnosis. And this is his ECG, which shows a sinus tachycardia and a non-specific ST segment changes. So now, what's your final diagnosis? I think you are able to diagnose the patient now. So now we have a new diagnosis of a cardiogenic shock. Yes, thank you for everyone on the chatting. Yes, it is. It is a viral myocarditis. Yes, thank you. Thank you for my audience. Yeah, keep on interacting on the chat window, please. Thank you. So now we have a new diagnosis of cardiogenic shock, secondary to acute viral myocarditis and complicated with pulmonary edema. It wasn't an acute bronchiolitis. It was a tricky case. And the immediate intervention you decided to do is to transfer to the pediatric ICU for intensive care monitoring and management, and to contact the PQ nurse in charge in order to sort out the availability of the bed, and the attending consultant, and the pediatric cardiologist for urgent consultation. So this is our first learning point for today. So you need to recognize heart failure as a cause of respiratory symptoms. So wheezing in our case was related to cardiogenic pulmonary edema rather than primary respiratory pathology. And to suspect myocarditis when viral illness is associated with symptoms of heart failure, persistent tachycardia, abnormalities on either chest X-ray or ECG, and moreover, I can add that the high lactate of 5 cannot explain an underlying respiratory illness. Combined chest X-ray with ECG testing improved diagnostic sensitivity to 97% percent compared to 55% for chest X-ray alone or 93% for ECG alone. Back to our case scenario. So you contacted the nurse, PICU nurse in charge, and she informed you that the bed will be available within 30 minutes. So you need now to initiate the management of cardiogenic shock in the ward while awaiting transfer. And this means you are going to manage the case without a mechanical ventilator and without a central line using the two peripheral cannulas. So from the airway and breathing perspective, you can increase the supplemental oxygen in order to maintain saturation above 90%. And if the CPAP is available in the ward or HDU level, it could be used as a temporizing measure to manage the cardiogenic pulmonary edema until intubation and ventilation are happening in the pediatric ICU. From the cardiovascular perspective, you can start low-dose adrenaline infusion of 0.02 up to maximum of 0.1 mic per kilo per minute through the peripheral cannulas using the peripheral concentration of adrenaline infusion, and to continue monitoring and to set up the blood pressure every 5 minutes. Regarding fluids, so it's according to the clinical situation of the patient. If the patient is still in shock and there is no signs of pulmonary edema, you can use fluid boluses of only 5 mL per kilo and monitor during and after the bolus. And you need to stop the fluid if there is worsening respiratory status or newly developed hepatomegaly. And if pulmonary edema developed, as in our case scenario, you can give an IV furosemide of 0.5 milligram per kilo. The PICU bed is now available, and the patient has been transferred to the intensive care unit. And your attending PICU consultant decided to proceed with rapid sequence intubation and mechanical ventilation. So, regarding airway, and I'm going to ask you, my audience, please answer in the chat. During rapid sequence intubation of a viral myocarditis patient with cardiogenic shock, what concerns you the most, and what do you need to be ready for? Yes, thank you. Thanks for you all. Yes, it is. We need to be ready for a possible cardiac arrest, as it could be happen during the induction of these cases. Thank you. So you need to be ready and prepared with induction medications, which contains a cardiac arrest medications. So prepare resuscitation doses of adrenaline of 10 mics per kilo and start peripheral low-dose adrenal infusion prior to the induction and during the induction as well. And avoid high doses of adrenaline as it has a rhythmogenic effect, and be ready with the defibrillator standby and the crash trolley bedside. And it is advised to use the induction medication for these cases, fentanyl and ketamine, as ketamine doesn't drop the blood pressure, and to avoid propofol and midazolam as they cause myocardial depression. Our muscle relaxant of choice is rocuronium, and it is advised to avoid succinylcholine as it has many side effects as hyperkalemia. The onset of the drugs may be slow, so you need to wait for the drugs to work. And if fluid bolus is needed during the induction, use 3 to 5 mL fluid boluses. And the team, you need to be ready for a possible cardiac arrest team. So you need to assign rules for a cardiac arrest team combined with the rapid sequence intubation team. For example, the first intubator, if a cardiac arrest happens, he can be responsible for the airway, and the second intubator, if a cardiac arrest happens, he can be responsible for the defibrillator, and the nurse who's passing the tube for the intubator can be responsible for compression. What about breathing and mechanical ventilation settings? So we have a lung protective strategy in heart failure. It is advised to use a pressure control and to use an optimal PEEP along with FiO2 to keep the saturation above 90 to 92%. Meanwhile, avoid very high PEEP that goes down with the venous return, and the PIP is advised to be limited to generate a low tidal volume between 6 to a maximum 8 mL per kilo. And this is our second learning points for today about benefits of mechanical ventilation in cardiogenic pulmonary edema. So what the mechanical ventilator does in the cardiogenic shock, it increases the intrathoracic pressure, and this is decrease the post-load on the left ventricle and decrease the preload on the right ventricle, and this will increase the left ventricular ejection. It takes over the work of breathing as well, and this decreases the oxygen consumption. It re-establishes the functional residual capacity, and it improves the oxygenation, and all of this will increase the cardiac output. What about the circulation management? And here I mean the inotrope of choice. So in cardiogenic shock, in this case, the acute viral myocarditis, our first inotrope of choice is milrinone, and we start with a low dose of 0.5 mic of kilo per minute, and we can increase up to a maximum 1 as needed. And if in poor resources settings, if milrinone is not available, dobutamine is advised as an alternative. And for persistent hypotension, noradrenaline is the first line vasopressor combined to milrinone. And for inotrope resistant cardiogenic shock, as in our scenario, we replace the noradrenaline with adrenaline. For a vasopressor-resistant cardiogenic shock, if both adrenaline and noradrenaline are not working, we can initiate vasopressin, and for prolonged refractory shock, we need to refer to ECMO. And this is our last learning points today about the inotrope management. So milrinone is typically used as first-line therapy for inotropy, and noradrenaline is the first-line vasopressor combined with milrinone to achieve adequate perfusion pressure, particularly with patients with low cardiac output and reduced vascular resistance and persistent hypotension. Vasopressin could be used as a good alternative to noradrenaline, as well as it augments the perfusion pressure without touching the myocardium, and adrenaline is reserved for cases of hypotension and cardiogenic shock, as it carries a high risk of chronotropic and arrhythmogenic effect, and dopamine is not recommended for use in children with cardiogenic shock anymore. I hope this was useful, and thank you all for listening.
Thank you very much, Dr. Rehab, for this nice clinical flow of a sick child that started from presentation till management and the challenge in the management.
Thank you.
Some of the challenge, Doctora, that we found that when the respiratory cardiac deterioration child present in a respiratory presentation, which make it difficult for people to differentiate between respiratory and cardiac. Any hint, any point that can help the audience differentiate will be appreciated. Thank you.
Yes, there was many alarms missed actually in our presentation. First, the low oral intake cannot explain shock. Second, the high lactate cannot explain, of 5, cannot explain respiratory illness. The persistent wheezing and the added crepitations when we give the fluid therapy. So if you have a shock which deteriorate on fluid therapy, this is not a hypovolemic shock. We need to consider a cardiogenic shock. So many alarms have been there in our case, and it cannot be only on viral respiratory cases. Also, viral gastroenteritis could present an underlying cardiogenic shock. So it's any viral illness with heart failure.
Thank you, Doctora. There is a question, nowadays the high flow nasal cannula started to be used more than previously instead of non-invasive mechanical ventilation. So what's your experience in this point?
Our experience after the COVID era is that high flow nasal cannula is a good alternative to CPAP, especially in the ward level. So we can apply the high flow nasal cannula in the ward while we cannot apply the CPAP, and it has similar effect. So a high flow nasal cannula of 2 liters per kilo has an effect similar to a CPAP of 6 to 7, according to the recent researches in the COVID era. I don't have the research now, but it's more than one research. We can rely on it, especially in the ward level.
Yeah, thank you. There is one of the audience asked it is that pro BNP can helpful to differentiate respiratory and cardiac.
Yes, of course. If we suspected cardiac, we are going to send all of these enzymes if we suspected. But if we didn't suspect, we are not going to send it yet.
Yeah. Thank you, Doctora, for a nice presentation. And because of the time, I will let Doctora Asma Solo to present the next speaker. Welcome, Doctora Asma.
Thank you very much, Dr. Turki. Thank you, everyone, for your attention and for listening. And thank you, Rehab, for that very excellent presentation. So it gives me pleasure in introducing our next speaker, who's Professor Anna Gunz. Professor Anna is a pediatric intensivist at the Children's Hospital London, Ontario in Canada. She has quite an extensive CV, but I'll try and summarize that. So she's the founding medical director of the Children's Environmental Health Clinic in Ontario. She's also associate professor at Schulich School of Medicine and Dentistry at Western University, and she holds various roles in medical education. Most recently, she is the Program Director for Pediatric Critical Care at Western University. Professor Anna also has clinical expertise in transport medicine, and she was the medical director of the largest critical air medical transport service in North America. She also has broad research, education, and advocacy portfolios in the fields of planetary health, including health monitoring of climate change, meaningful supports for youth with eco-distress, and increasing community and healthcare facilities understanding of the urgent need for the mitigation and adaptation measures, including holistic benefit of nature-based solutions. And she is the knowledge exchange lead for climate change, environment, and health collaborative. So with that extensive CV, we welcome Dr. Anna Gunz to give us a talk about the management of a deteriorating septic child. Anna, the floor is yours.
Thank you so much. And thank you all for this opportunity to chat with you today. I am going to talk about, I'm going to repeat myself. Look at this. We're talking about the deteriorating septic child. What I'm going to do is we're going to go through a case presentation, just like with Dr. Gad. And I'm going to take you through a bit of the story. A lot of this centers in the Surviving Sepsis guidelines, but I'm trying to give you a bit of a clinical spin. I recognize that we all practice in different locations. So I practice in Canada, and we're lucky in terms of we're in a publicly funded high resource setting, but I want to bring in some pieces and leave it for nuances for wherever you are in the world. And this is just a picture of the Northern Lights because it is one of the most beautiful things from our north. So let me actually move forward though. So let's start with our patient. So our patient is called Denver. He is a healthy and active boy. And I also note this because, of course, sepsis and septic shock can occur to anybody. And while we see them ill and unwell, this is how the family and sees the child. And so it's something when we think about moving forward and how they're perceiving the children is always an important thing to think about, because it's also a very extremely stressful and traumatic, not just for healthcare providers, but for them as well. This is based on a patient that I saw years gone by. So I'm going to say from Southern Africa. He's been here for about 3 months now and living with some relatives for a bit. Cough and fever and URTI symptoms for the last 3 days. Fully vaccinated. Has been vomiting for the last 12 hours and decreased energy. So these are his vitals right now. So his heart rate's 190, and I'm going to say he's 6 years old. So this is tachycardia for that age group. Sats are 93 on room air, and blood pressure is 170 on 80, and his temperature is 39.8. So definitely has a fever. So what are we going to do? The first thing we have to do is we have to decide on the diagnosis. And for that, it's important to look at our definitions. So the adults, there's been the sepsis 3 criteria in the adult world, and they have had consensus about changing their definitions of sepsis. In pediatrics, there's ongoing discussion and work in that area, but the latest guidelines talk about septic shock and sepsis-associated organ dysfunction, which I actually enjoy the simplicity of it as a clinician. So from a septic shock perspective, it's severe infection leading to cardiovascular dysfunction is how they talk about it in Surviving Sepsis campaign guidelines. And when you're talking about cardiac dysfunction, they're meaning hypotension, need for treatment with vasoactive medications, or impaired perfusion, which is really what, as clinicians, we're seeing. And when it comes to organ dysfunction, so severe infection leading to cardiovascular and or non-cardiovascular organ dysfunction. So how do we make this diagnosis? Because the truth of the matter is, and we will get to differential, this can be the presentation of many things, including myocarditis, as we've just heard in the previous presentation. So what are we going to need for information? So one of the things that is called for in the Surviving Sepsis campaign now is a big emphasis on protocolized and routine screening and bundles in recognition and management. So early recognition is key. And systematic screening protocols, there's lots of different research about all these different protocols that are screening tools in, yet they can't recommend one at this point. I think every center, larger centers have decided on which one it wants, but early identification is key here, because at the end of the day, you can have bacteremia and early infection. And the earlier you get effective treatment, you get effective organ perfusion, the better the lower the mortality rate, the lower the morbidity rate, and the lower the risks associated with the care of ʻSCOBAN. So you're going to need to take a relevant history. And in this case, it's, travel, infectious history, exposures in the environment, water, and other contacts will be important. If they have other medical conditions, like in past medical history, specifically, there's no hemoglobinopathies, this child has been otherwise well, no suggestions of immunodeficiency. And when we're thinking about sepsis, we're thinking about an infection. So how are you going to really hone in on this infection? There's also investigations we can do. So blood cultures, and there's an emphasis as well on early, at the end of the day, if you can take a blood culture, take it early, and ideally before antibiotics. But if that is not the case, then give the antibiotics and deal with the suspected infection later. If there's any site or focus of infection, like an abscess, that can be taking a sample of that fluid, urine cultures, sputum cultures, nasal pharyngeal swabs for viruses, etc. Make sure that those are taken as well. White blood cells. So in a CBC, everyone has it's a knee jerk, right? Everybody does a CBC. I'm saying in this count that the white count is normal. There's no blasts on the cell. It's not leukemia that it looks for. But I think this is and CRP or prolactin, procalcitonin, have been started to use. Unfortunately, there's a delay. And I think one of the things to keep in mind, and this is not in the guidelines, but practical appearance is that sometimes when you're dealing with a septic patient who has a severe inflammatory response, the markers of inflammation you will see later and delayed, especially from the bone marrow. So it's with time that you see that. So relying on a normal white blood count is not going to be very helpful. If it's low, it's more indicative. And certainly you can have normal inflammatory markers, such as the CRP when you come in, procalcitonin if you have it in the center, which we don't. The other component of diagnosis is what other centers. So in this case, this child has an X-ray with a pneumonia, in situ. The cardiac silhouette doesn't look particularly enlarged, because every time you're thinking about this, you want to think about what's supporting your diagnosis and what else is on the differential. And then the other piece is you want to evaluate for cardiovascular dysfunction, right? That's the other piece of sepsis. So here we have his vitals again. And so he's definitely tachycardic. One of the first things we're going to look at is it sinus tachycardia. I have seen more than one patient we get consulted on, and they've actually had an SVT, and it's been missed because they're coming in with this context of this fever and other symptoms as well. Their saturations are not actually that bad on room air, and the blood pressure is 170/80. I'm going to ask you in the chat quickly, does that normal blood pressure preclude cardiovascular dysfunction in this child and potentially septic shock? No, I like that one. Yes, no, absolutely not. And that is the tricky thing. In addition to that, as we know, hypotension can be a late sign, and it can be really stressful and difficult, right? So I can think of, and there's other, and I feel like there's a few things when you're looking at a septic child, when you're looking at these vitals and hypotension. So for example, one of them is that I feel like because there's this knowledge of, I hope they don't be hypertensive. We know that once they're hypotensive in children in septic shock, they really deteriorate. There's always sometimes this bias against it. So people will be doing what they can to hypotension. And there's a few things that I've seen as well that can happen when they're deteriorating. So one is all of a sudden the blood pressure is not measurable. And so everybody is troubleshooting that blood pressure cuff, but feel a pulse. And in this sense, I just act as if they have hypotension, because everything I'm going to do at the end of the day, it's better to act, and I can always reverse those. The other one is that I find sometimes the patient's heart rate the blood pressure cycles high, and then it cycles low, and then it cycles high, and this cycles low, and this is with an automated blood pressure cuff. And I'm not sure if it's a device issue or measurement issue, or there is this, actually happening physiologically. But with the times I've seen that comes right before the patient has significant hypotension. And the other piece is the narrow pulse pressure. So patients who have, a blood pressure that's, especially babies, I found they're very good at vasoconstricting. So 99/80. Often people will look at that and feel reassured, but that always makes me very nervous, because that means that this patient is in shock, right? If you think about it, they're vasoconstricting, they're trying to increase their cardiac output. So I always beware of that patient as well when we're looking at vital signs. Other pieces there are their CNS symptoms, and this is the other piece for recognition. So are they acting inappropriate? And so what I would say is, when a stranger walks into a room, doesn't matter how sick the child is or how old they are, it is not normal for them to look at you, answer the questions, and sleep, nor is it normal for them to sleep. And so you really want to look at that and be suspicious, because that early change in their mental status is a real good sign of early shock. The other piece with it is if they have significant dysmorphisms, and it's often easy for staff and people around them to think that this is normal. However, the truth of the matter with this piece being is that you have to ask the parents, how are they normally? Because we can absolutely have a bias and not identify these children. And yes, sorry, I see a comment about wide pulse pressure. Absolutely, wide pulse pressure is important too. However, reason I mentioned the narrow pulse pressure is I find it's often easy to miss. That one, people feel like the blood pressure is good, and so it's reassuring. Respiratory support, so definitely tachypnic patients, silent tachypnea who aren't working, that can be missed, but that is usually a sign of acidosis. And in this case, you can also evaluate it not only with how much oxygen you need, what's their work of breathing, do a blood gas. And in this case, this patient has a metabolic acidosis, lactatemia. So if you can measure a lactate, not all, I understand that, in some labs, you have to have a different strip that's refrigerated to measure lactate. So if you have a lactate, absolutely measure the lactate. A normal lactate does not preclude the possibility that this patient is in septic shock. And if you do not have access to a lactate, it's a helpful measure. It's a helpful measure to look at early normalization, but not a necessity in that rate. renal dysfunction, liver enzymes. These are all things that looking at the end organs, as well as your hematological status. That includes looking for things like DIC, so looking at your coagulation status, as well as thrombocytopenia, looking at your smears or hemoglobinopathies. There's something else going on. So when you have this, at the end of the day, you have to then come back to this differential diagnosis. And so, you know, what I see, it's this dance between moving forward, getting investigations, treating, and then going back to the differential. And I find as long as you keep dancing in these questions and check them off or move back and forth, then you won't miss it. But if you don't have, if you just jump on the sepsis train too early, then you might. So could it be a hyperinflammatory state? So certainly if I had a child with Kawasaki's disease that presented exactly like septic shock, and I believe they had septic shock until they just continued to not respond. Could it be anaphylaxis? Is there anything about allergies? Could it be a toxidrome? And then, of course, I have that heart beating there because, you know, cardiogenic shock, myocarditis, pericarditis, all of these things can certainly present in this way. So in this case, this child has sinus tachycardia, some myocardial dysfunction, but a structurally normal heart, and no history of anaphylaxis. Myocardial dysfunction is a common feature of sepsis. So what are our treatment priorities? So sepsis is a lot to go through, and I recognize in a limited time, but things to think about is number one, is a system level where you're working as bundles and protocolized care is really emphasized and has been shown to improve outcomes. So it doesn't matter where they're coming or where they're presenting, ensuring that people know what to do and you have some therapy treatments is good. And then you want to think about the acute system, like the acute, what's happening around you, but also what are you going to be managing in the hours to days to come for this patient, and what are their long-term outcomes? And one of the biggest pieces here is fluid management. So knowing whether you have a pediatric ICU, can you support them with a ventilator, will actually help you titrate your fluid therapy. And the therapy-diagnostic relationship, I talk about this dance of constantly questioning yourself as you go through and you're resuscitating. All that being said, surviving sepsis has stayed the same in terms of source control and early broad-spectrum antibiotics, and then shock reversal and hemodynamic monitor. Those are the big priorities at the patient level. So broad strokes here, in terms of source control and antibiotics, it's just going to say that about 17,000 times. That means if you have an abscess, is there something to drain it and give broad-spectrum antibiotics. If the patient is immunocompromised, depending on where you are in the world, what kind of infectious the antibiotograms, what kind of infectious agents come up with, like a regional, you know, those are good. That's going to be knowledge that you're going to have, and you want to have the best conversation and thought about your antibiotics based on where you are and what the likelihood of it is. And also you can use, obviously, some of these other diagnoses and infectious things might show up in your organ dysfunction and pattern organ dysfunction, or the patient's presentation that might steer you in one direction or the other. So definitely keep that in your differential. From a shock reversal hemodynamic monitoring perspective, the first thing is you have to look at hemodynamic targets. So the new guidelines talk about MAPs, so mean arterial pressures as targets. Low normal is what people sit with. However, if you can't accurately measure that, certainly systolic blood pressure, and I think that there is some piece, this is going away from surviving sepsis, but I feel like there's some piece of practicality here. So what is, you have to look at the entire patient. And again, you can have a normal blood pressure, you can have a low blood pressure, but an adequate cardiac output. So if the patient is not meeting some of these targets, or maybe there's a complication like they have ARDS at the same time, which is inhibiting your ability to meet some of these targets, you always have to go back to you have to reassess this and decide which you're going to use. Other things that you can use are a mixed venous if you have a central line, cardiac index, your systemic vascular resistance, if you have the ability to do that, and if you're skilled in those monitoring. And then there's always the lactate and the urine output and the acidosis and how they're perfusing. And if all you have is your clinical exam, use your clinical exam to try and decide whether you are where the patient is in a good state with your resuscitation. And those are really key, because as much as we want to get on board, stop this process and support their hemodynamics, we also need to know when we can step back and let the healing of the patient move in, because at the end of the day, the more we do, the more we give, there's always complications to those things down front. In terms of shock reversal, there are a number of things on this list to think about, and very briefly going through them. Fluid resuscitation. So certainly that remains a mainstay. So 40 to 60 mils per kilo is often what is still quoted as is adequate to give before starting inotropy. If they're hypotensive, giving between 10 to 20 mils per kilo. And there's a consideration. So if you don't have access to a PCCU or mechanical ventilation, there is conversation about whether IV maintenance fluids are used instead without this fluid resuscitation. At the end of the day, you have to treat the patient in front of you. With this, though, the question is always, are they fluid responsive? And how much, and do we use a low volume strategy or high volume strategy when we're resuscitating our patients? Because the more fluid we give, we understand that it actually changes their outcomes long term. And so there is data from RCTs that is about to be released. But at the end of the day, I think that the practice and where we sort of sit now is, I feel like it's Goldilocks, right? So unfortunately, there is no perfect way to know if a patient is fluid responsive. There are ways to use POCUS, to look at the blood pressure, the heart rate, etc., to get a sense of whether the patient is fluid responsive. But at the end of the day, there's not one perfect thing. So taking that all in response while you're giving them fluid and thinking of the fluid you're given as a medication, so that you're not going to walk away. You're not going to just give it and leave. You're going to be thinking critically as you're giving the fluid about whether it is helping or hindering. And if it is hindering a lot quite early, gosh, it's a great time to think about that heart again and the function of it. The other piece is talking about like giving excessive amounts of normal saline can lead with hypochloremia. Does it affect mortality and morbidity in the pediatric patients? It's not necessarily known at this point, but there is recommendation about having balanced fluids in the guidelines. Vasoactive medications. So this is the other thing. At the end of the day, if the patient is hypotensive, treat the blood pressure. And now it's epinephrine, norepinephrine, cold and hot, warm shock are out the window. Pick a medication that makes most sense for you, that everyone's comfortable with as a starting place. The sooner you get a vasoactive medication on for someone who needs it, the mortality, there is hopefully a mortality benefit from previous trials in the past. Dopamine is not recommended as a first line anymore, but it is a very helpful medication in a lot of places where you don't have to premix it. It comes in premixed bags. So if that's all you have, we service communities in remote locations, and it's very stressful. There's only a few people there resuscitating this child. Then just grab a bag of dopamine. You can hang it while we'll give you instructions about how to mix your inotropes. Milrinone can be used if you think it has physiologic benefit, and vasopressin in that lines. And then in terms of supportive therapy, don't forget about glucose. These patients still need dextrose. Insulin is not recommended as a baseline. Normalize the calcium. And these are not in the guidelines, but certainly clinically, maximizing your ionized calcium, your potassium, your magnesium, and your bicarb are all things that are often done in practice without evidence to help support those hemodynamic patients. And then the other big piece here is respiratory support. So remember, oxygenation is key. So provide them oxygen and think about your oxygen consumption. And one of the ways you can improve it is with positive pressure, as you've just heard in the previous one. Intubation, when you have this plateau of resuscitation with someone in septic shock, can actually improve the cardiac output seen clinically in a lot of situations, because you're taking that work breathing off and you're also supporting that heart. Non-invasive and high flow nasal cannula are often used in that piece as well. And if the patient has ARDS as well, interventions such as nitric and proning and even oscillation are all their considerations to maximize your oxygenation. And then the final change here with blood products is certainly in a stabilized patient, hemoglobin of greater than 70, and stabilized is no inotrope changes for 2 hours and they have acceptable blood pressures, but there's no recommendation above that. In practice, a lot of patients pick a hemoglobin of around 95 for that. And they do say that now prophylactic platelets or plasma, there's not targets for non-bleeding children. And so at the same time, they caution, and this is the caution I have, platelets of 10 to 20 in a pulmonally septic patient, I'm not sure I would feel comfortable with that. And Plex and IVIG don't have a routine place unless you have a specific indication based on what the child has. And let's just go back to this patient. Let's say you've done all of this, still really hypotensive. you've intubated them, and you're kind of stuck. So the big conundrums that have been there since I've been training is the cortisol conundrum. So there's the SHIP trial ongoing, looking at, does stress dose corticosteroids help for patients with suspected relative adrenal insufficiency? If this patient has any history of steroid use, or you're concerned about significant adrenal suppression, then absolutely they need high dose steroids. Renal replacement therapy is an adjunct and a supportive therapy that can be absolutely used. And then ECMO is also, if you're in a setting where ECMO for sepsis can be indicated in a high volume setting, and that's where you talk to the local setting, or if that's you. And that was my sepsis in a nutshell. And yeah, if there's any questions.
Thank you, Doctor N, for this nice comprehensive presentation. Wonderful. One of the audience has a question about the clinical significance of saline-induced acidosis. It's also very interesting.
The clinical significance of saline?
Saline to induce acidosis? I guess she means that the saline may induce complications. She's probably asking about the value of saline versus ringer lactate as initial fluid resuscitation.
So in adult trials, from my understanding, certainly there's been, a lot of concern about hypochloremia from that, and they've made recommendations. Now, in terms of pediatric data, to my knowledge, there hasn't been comprehensive data that has actually come at this point to point to ringer's lactate or not. The guidelines say to use it. However, what I will say is at our center, there is an expense, and we will use saline. And at some point, we will manage these things, and we will look for, a balanced and hypochremic metabolic acidosis, but it doesn't necessarily change. And we might change our fluid resuscitation with that, but our front line right now is still saline. It does cause a hyperkalemic acidosis, but metabolic acidosis, the question is, does it actually cause, does it actually change your long-term outcomes with the patient? And I think that's the data that we are not, not as clear on. And, pediatric kidneys, now I'm not the nephrologist online here, but children have different renal clearance. And so there's also a lot more concern about hyponatremia. So I think that in the future, we will have a more definitive answer. But for now, I think, you have to think about resources and what's available as you're moving forward.
Okay, thank you very much. Also, there is another question about the use of sodium bicarb for correction of acidosis in shock.
Yeah, so again, not supported, in terms of the literature, and you can see different surveys, and people do different things, but in general, from a pathophysiological perspective, there is this understanding that, the more acidotic the patient, can they actually respond to can the receptors respond to the inotropes that you're being given? And the belief is no. So the majority of patients clinically, like in our clinical practice, we will absolutely give sodium bicarb to bring the metabolic acidosis. So targeting a bicarb between 15 and 18, we will give sodium bicarb in that place. I think the other thing to keep in mind is there's the evidence, there's the trials, and then there's the patient in front of you. And when a patient is that sick, it's often that we will do things that we are just trying to move the patient in front of you. And that's the importance of the literature, to look at these things. But I would say that certainly I from the practice consensus here, we will often give sodium bicarb in 1 millimole per kilo aliquots in order to achieve, to improve that metabolic component of the acidosis.
I guess, as you mentioned, Dr. N, that the practice of early initiation of antibiotics within the golden hour to eliminate the source would be the most essential step to manage the septicemia and septic shock and prevent that progression we have seen from compensated to decompensated or hypotensive shock, where it's usually irreversible. Yeah,
and I think the other thing to keep in mind is that, depending on the pathogen in the organism, at the end of the day, it's the hosts, we have this pathological inflammatory response. And some organisms have toxins that are excellent at, activating our inflammatory cascades. And it is often not the bacteremia itself, but this inflammatory response is causing all of this instability. And that, that's another piece that it can feel very frustrating and frightening and scary, right? When you have this patient in front of you who's deteriorating, and maybe, I see this question about when do you choose noradrenaline or norepinephrine and epinephrine, vasoconstrictors. This is the whole piece when you have endothelial dysfunction. You have a patient that has purpura fulminans. Sorry, I feel like I'm missing, if that's a word, right? And you're looking at this, and you have this hypoperfused state at the peripheral level. Potentially, you're not getting an oxygen saturation distally. So we've put it on earlobes and noses in order to pick up an oxygen saturation. There's a lot of conversation about inotropes and what, is it the vasopressors that are working? And certainly you can add other things such as Melanom with it, but we have to remember that there's dysfunction at the endothelial level. It's a microperfusion. And it's a cascade that has been set off that we are left dealing with. And ultimately, you can have patients with amputations. There's conversations about peripheral vasodilators and heparin and all these other pieces that are used to try and mitigate the damage. But unfortunately, it's still unclear what is, if things are effective, and what is more effective. And usually, at least where I practice, is much more rare. So I find that we end up with a sort of a bias towards what we've used. But in that case, when we're talking about saving limbs and distal extremities, it's really hard, I think, as pediatric intensivists to not try anything at that point. But I just caution people to go back to the vasoconstrictors and consider that, because you have to understand there are two processes going on, and you ultimately need to maintain perfusion to the brain, heart and lungs, and you're managing a lot of different pieces of information at once. And in terms of epinephrine, norepinephrine, you can base it on, the pulse pressure. Certainly,
yes, I think he asked this question for.
Yeah, you can use norepinephrine for that.
Pulse pressure.
Yeah, I think ultimately, though, our exam is flawed, and both of them have inotropic support. So just start something, I think, is the bottom line there. Just don't have to start something, start what you're comfortable with. And then there's nuances. Now, I will always start epinephrine at a low dose to support the myocardium, because I really believe that I'm doing a good thing when I'm doing that. And then I build on norepinephrine to it. Can I tell you that that's the right way to do it? And from physiology, no, but that's my comfort level. Unless they're absolutely vasoplegic, I always want to support the heart, and then I add on norepinephrine. But that's my opinion. There's other colleagues who start norepinephrine, and at the end of the day, you want to early inotropes to start that process. And I think that you could probably, actually, it'd be interesting to ask everybody on the panel what they do as well, from this as well.
Thank you, Dr. Anne, very much for your time and for a very informative lecture.
Thank you so much.
It was very simple and practical.
Thank you so much, Dr. Anna, for the fantastic presentation. I think it's a time for Dr. Michael Canary to give us the closing remarks. Dr. Michael Canary is a professor of pediatric critical care at Yale University, very well known. And he is also trying to help unprivileged community and low-income countries. So thank you so much, Dr. Michael Canary, to be with us today.
Thank you, Dr. El-Hussein, and Dr. Ragab and Gunz. Thank you so much for those excellent cases and the wonderful questions that were asked. I think that, for our learners out there, of which there are several hundred actually, I think that I think the case-based approach is really the most effective way to challenge learners to get from a textbook to the bedside. But even at this stage in my career, when I hear a colleague present a case, I'm instantly engaged, and I think these two cases were engaging in different ways. But you're sort of drawn in automatically and begin sort of incorporating new data and sort of formulating your own differentials and thinking of the next steps you would take. And it's truly exciting. And I think that as a learning tool, I think they were very effective and they were both great cases. Just to talk briefly about some specifics is that what impressed me, Dr. Guntz's case, just the thoroughness, right? So even the attention to detail, discussing the CBC and commenting on the presence or absence of blasts. This is important stuff. Details are important. And then just the thoroughness with which she assessed and commented on the vital signs. There may be places where you're practicing where that's all you have is the SAT-pleth or the blood pressure or the heart rate. And you have to be very extremely analytical in optimizing the data that you have at your disposal. So thank you for those. And then, of course, running through the management of septic shock. I love the cortisol conundrum, right? As long as I've been practicing, it's been the same thing. And hopefully we'll have some insight into that. It's a very funny, when I think about Dr. Raghab's presentation, it's sort of, I love the way she highlighted the particular learning points. In particular, the perils of intubating a patient in fulminant cardiogenic shock. I think all of us recognize that's intubating someone who's in shock is very perilous, but someone in cardiogenic shock is extremely high risk. And I think, drawing attention to that and then the subsequent management, I think was important. But I think what I liked most about these presentations is something that I try to emphasize with my learners, and that is that there's some misconception that being a critical care doctor is all about sort of dashing in for heroic measures. But in fact, it's really most about recognition and monitoring. Is something as banal as that. Recognizing patterns and then intervening and monitoring thoroughly the response to your interventions, but also, entertaining other diagnoses. So, we all make provisional diagnoses when we're in front of a patient. We see X, Y, and Z, and so we say, okay, this is what I think it is now, and so I'm going to do this. But what's important is monitoring the patient's response to that. Managing critically ill patients is not a spectator sport, and it's very funny, Raghab, you brought up a scenario that I actually discussed on rounds this morning. That is, you have the sort of cookie cutter bronchiolitic in front of you, but oh wait, it's not bronchiolitis. And so you take the first steps in the management of what you perceive to be the most likely diagnosis based on the information you have at that time. However, because you're thorough and you go back and you're monitoring carefully, you say suddenly, this is not bronchiolitis. This is a patient who's in shock. And oh, guess what? I hear a gallop, right? So you don't hear a gallop for a bronchiolitic, right? And so suddenly your management, your diagnosis changes and you change course. You have to be nimble, but you make a provisional diagnosis and then you start this endless cycle of intervention and monitoring. And, the final comments I would make is, that it's a very dynamic process, and, managing critically ill children is not a spectator sport. And I thank you both for those excellent presentations and the questions by my colleagues and the opportunity to be with you today. Thank you so much.
Thank you so much, Dr. Kanari, for this closing remarks. Just housekeeping things. Our next webinar for the Pediatric Critical Care Fellowship will be next month, May 27. So please mark your calendar. And I saw several questions about fluids and saline and ringer lactate. So actually we have on May 19 a fluid update webinar with the International Fluid Academy with Dr. Manu Melbrin. So please also mark your calendar if you are interested in fluid management of pediatric and even adult patient. Please join us for our upcoming webinar on May 19th. So you have 2 dates, May 19 for the fluid webinar and May 27 for our Pediatric Critical Care Fellowship. And we are going to send you more notification about that. I have seen also several questions regarding the fellowship. Don't worry about it. The fellowship is going to start by the end of July. So we have still at least 3 months. And we have your email address because you registered to our webinar. We have your phone number. We are going to create WhatsApp group, and we are going to share information about the upcoming events and also some scientific materials for free. So we'll send you notification about this WhatsApp group to join, and we'll keep in touch. With that, I thank everyone who contributed to this fantastic webinar today or tonight, and we'll see you next month. Thank you. Bye.
شكرا لك دكتور.